Our next speaker is Dr. Linda Chao. Dr. Chao is PhD professor at the University of California, San Francisco. Dr. Chao is a highly experienced and skilled teacher who shares her expertise in the Department of Radiology and Biomedical Imaging and the Department of Psychiatry. As a former student of biological science at the University of California, Davis, Dr. Chao went on to complete her PhD in neuroscience in 1996. Past 11 years, she has been a leader for the psychiatry block of the Interdepartmental Studies course, Brain, Mind, and Behavior, where she shares her passion for the subject with first-year medical students. Dr. Chao's research activities primarily focus on the understanding on how normal aging, neurodegenerative process, stress, and exposure to neurotoxins affects the brain and cognition. Her ongoing project, funded by the Department of Veterans Affairs, looks at the effects of low-level exposure to sarin on the brain structure and function in Gulf War veterans. She also has another project funded by the U.S. Army Military Operations Medicine Research Program, which seeks to investigate the links between post-traumatic stress disorder and dementia. Dr. Chao today will be discussing veteran sleep needs. Thank you so much, Dr. Chao, for being with us today.
Okay, great. I will get started. So thank you for the invitation and for bearing with the technical issues. So today I'm going to tell you about some of my research looking at treating sleep disorders as a possible gateway for treating Gulf War illness. And by Gulf War illness, I'm referring to a cluster of medically unexplained symptoms that affects veterans of the 1990-91 Gulf War, which is also known as Operations Desert Shield and Desert Storm, which took place over 30 years ago. And the Gulf War is unique for its brevity. There was only 6 weeks of airstrikes followed by 4 days of ground combat. And because the war lasted less than 2 months and there were relatively few casualties, it was initially declared a decisive victory. But unfortunately, shortly after the soldiers returned home from that conflict, many began to complain of a variety of symptoms that weren't adequately explained by established medical or psychiatric diagnoses. The symptoms tended to vary somewhat from veteran to veteran, but they generally included some combination of fatigue, headache, widespread pain, memory and concentration problems, sleep disturbance, respiratory and GI issues, and unusual skin rashes. This constellation of symptoms was originally dubbed Gulf War syndrome by the press, but it's also been referred to as undiagnosed illness, chronic multi-symptom illness, and Gulf War illness, which is the term that I will be using for the remainder of this talk to refer to this condition. Unfortunately, few, if any, of the Gulf War veterans who suffer from Gulf War illness have gotten better in the 30 plus years since the Gulf War ended. Now, one common symptom of Gulf War illness is sleep disturbance. I can't tell you how many Gulf War veterans have told me that they have not been able to sleep through the night in decades. And I've found a significant and positive relationship between insomnia severity, poor sleep quality, and Gulf War illness symptoms. So in both of these graphs here, I'm plotting Gulf War illness symptom severity on the y-axis. And the higher the scores, the more Gulf War illness symptoms or the more severe Gulf War symptoms a veteran has. In this graph here on top, I am plotting insomnia severity, and the higher the score, the worse the insomnia. In this graph here on the bottom, I'm plotting subjective sleep quality, and the higher the score, the poorer the sleep quality. And you'll notice that veterans who have more severe insomnia and poor sleep quality also tend to have more severe and or more Gulf War illness symptoms. The relationship is highly significant. So it's not surprising that veterans who have Gulf War illness, defined either by the Kansas Gulf War illness criteria shown here in green, or the CDC chronic multi-symptom illness criteria, or CMI, shown here in blue, have higher insomnia severity index scores and subjective sleep quality index scores compared to veterans without Gulf War illness, shown here in these lighter color bars. Now, cognitive behavioral therapy is a form of structured talk therapy that tries to help patients identify and replace thoughts and behaviors that can cause or make mental health issues worse. Research has shown that CBT, or cognitive behavioral therapy, is effective for a wide range of mental health issues, from depression and anxiety to eating disorders and drug and alcohol abuse. So, cognitive behavioral therapy for insomnia, or CBTI, is a form of cognitive behavioral therapy that focuses specifically on thoughts and behaviors related to sleep problems. And the goal of CBTI is to help patients develop habits and behaviors that promote good sleep. So, this positive relationship between insomnia severity and subjective sleep quality and Gulf War illness symptoms made me wonder, could it be possible that some Gulf War illness symptoms are causing veterans to engage in coping mechanisms that inadvertently promote or perpetuate their sleep problems, which in turn exacerbate other non-sleep Gulf War illness symptoms? So, for example, if a veteran has fatigue or pain, that may cause the veteran to spend more time in bed when he's not sleepy. But spending excessive amounts of time in bed when you're not sleepy can cause problems when it's actually bedtime. It can cause the veteran to do things in bed, such as eat or watch TV, that gradually over time, through classical conditioning, can cause them to stop associating bed with sleep. And CBTI can break this vicious cycle by teaching patients to replace those maladaptive coping mechanisms with habits and behaviors that promote good sleep. And unlike sleeping pills, CBTI has the potential to help patients overcome the underlying causes of their sleep problems. And because CBTI lends itself nicely to delivery by phone, we did the first Gulf War CBTI trial remotely, which allowed us to recruit Gulf War veterans from all over the country. Now, I know telehealth is pretty commonplace these days after the pandemic, but we started this trial in 2016. And at the time, doing CBTI remotely by telephone was pretty novel. So we enrolled Gulf War veterans who had Gulf War illness according to the Kansas criteria and insomnia disorder. Then we got baseline data from them and randomized them either to receive 8 weeks of CBTI by phone or to usual care, which we called our waitlist control group. After 8 weeks, the patients or the veterans randomized to usual care or waitlist had the option of receiving 8 weeks of CBTI by phone. And the veterans randomized to CBTI, we followed up with 6 months later to see how they were doing. There were no differences between the two groups at baseline on demographic or clinical characteristics. However, after 8 weeks of CBTI, the veterans in that group, which I'm showing here in blue, significantly improved on insomnia severity, subjective sleep quality, and Gulf War illness symptom severity compared to the veterans in the waitlist group, which I'm showing here in red. So remember, for all three of these measures, a higher score indicates worse symptoms. So the scores going down over time indicates improvement over time, which is why there were significant group by time interactions for all three of these measures. CBTI also had a significant and positive effect on fatigue, depression, and anxiety. So the veterans in the CBTI group had less fatigue, less depression, and less anxiety over time, whereas the veterans randomized to the waitlist group basically remained the same over the 8 weeks. CBTI also improved cognition as measured by the Multiple Abilities Self-Report Questionnaire. So on this questionnaire, the more cognitive dysfunctions you have, the higher the measure. And so the waitlist group appears to be having more cognitive failures over time, whereas veterans randomized to CBTI had fewer cognitive dysfunctions as treatment went on. Interestingly, there was no difference on this measure of pain severity, which I measured with the brief pain inventory. So both veterans in the CBTI and waitlist group experienced the same amount of pain severity, but the veterans who were randomized to CBTI, they were better able to deal with their pain, so it interfered less with their day-to-day activities over time, whereas that was not the case with the waitlist group. And this slide is showing you the follow-up data in the CBTI group at 6 months. And the veterans who are randomized to CBTI were, for the most part, able to maintain the gains that they achieved with CBTI. So they learned how to have healthy sleep, and they were able to maintain that 6 months after treatment ended. Now, obstructive sleep apnea, or OSA, is commonly comorbid with insomnia. And as is common in most sleep studies, we excluded veterans who had untreated OSA from the trial. Unfortunately, this caused us to exclude a quarter of the Gulf War veterans who were interested in taking part in our study. Now, there were a handful of veterans who had been diagnosed with OSA and were prescribed positive airway pressure or PAP treatment for their sleep apnea, but many didn't use their PAP devices or didn't use it enough to be considered compliant. And this caused us to exclude another 16% of Gulf War veterans from the trial for non-PAP compliance. And I suspect this non-compliance with PAP may be related to negative experiences that many Gulf War veterans have with face masks. Because there was a fear that Saddam Hussein might use chemical weapons against the Allied troops, many soldiers had to wear gas masks during the Gulf War. Consequently, many Gulf War veterans to this day cannot tolerate having a mask on their face as they're trying to fall asleep at night. Now, I have a colleague at the San Francisco VA who developed a treatment that she calls AIR, which stands for apnea and insomnia relief. So this treatment basically combines elements of CBTI, which I'm showing here on the right-hand side of the slide, with psychoeducation about sleep apnea and insomnia, PAP desensitization techniques, gradually teaching veterans through baby steps to become used to having a mask on their face, and PAP adherence techniques. So using motivational interviewing methods to try to get veterans to want to be able to sleep better and to tolerate the mask and to use it with regularity. So now I'm doing a follow-up study where we're recruiting veterans who have Gulf War illness, insomnia, and obstructive sleep apnea, which we're screening for with home sleep apnea tests. So there are these really small, compact, disposable items that you can send to people, and they can put it on while they're sleeping. And their sleep data goes to a cloud source, and we can look at it to see if they have OSA. So if a veteran has all three of these conditions and they're interested in participating in this study, we get baseline data from them, and then we send them PAP devices. And then we randomize them either to 6 weeks of air therapy or to 6 weeks of sleep education. So this time, instead of a passive waitlist control, we have an active control condition. And we're delivering air and sleep education over Zoom this time. So the patient can see the therapist face to face rather than just talking over the phone. After the air treatment is over, we're following up with the veterans who are randomized to air 3 months later to see how they're doing. Now, this study is ongoing. I'm currently recruiting Gulf War veterans for this study. So if you're a Gulf War veteran with trouble sleeping and you suspect you have OSA, I'm going to have a link to this trial where you can find out more information. But to date, 39 veterans have completed the study. And I'm going to show you some preliminary data from these 39 veterans. There are no baseline differences between the veterans randomized to air or to sleep education, or SE here. No baseline demographic or clinical differences. And so here are some preliminary data from the trial. This time I'm showing subjects randomized to air. Their data is in blue, and the subjects randomized to sleep education, I'm showing their data in orange. So right now I'm seeing significant group by time interactions on insomnia severity and subjective sleep quality, with the subjects randomized to air improving much more over time than the subjects randomized to sleep education. So remember, again, higher scores are bad, and so a decrease in score over time is good. For Gulf War illness severity, right now I'm just seeing a mean effective time. So both groups are improving over time. But I think when we recruit more subjects, I think this group by time interaction will come out, because here it looks like at the post-intervention time point, the air group is doing better than the sleep education group. So why am I not seeing a significant group by time interaction for goal for illness severity when I see it here for insomnia severity and subjective sleep quality? Well, I think it's because this time everybody is getting a PAP device. So here I'm showing you data from the first goal for CBTI study that I showed you earlier. And here subjects just have insomnia and they're just getting CBTI or nothing. This time, this is the data from the ongoing trial. Everybody has insomnia and obstructive sleep apnea, and we're sending everybody PAP devices. And I think that's why this improvement in the goal for illness severity seems to be greater in the sleep education group than the waitlist control group. And there was a small pilot study done by Mohammed Amin and his colleagues in 2011, where they showed that continuous positive airway pressure, or CPAP treatment, improved symptoms of fatigue and anxiety and in Gulf War veterans who had sleep disordered breathing. And so here are some preliminary data on depression, anxiety, and cognition. Right now, there's a trend towards a group by time interaction on this measure of anxiety. But for measures of depression and cognition, there are just significant main effects of time, with both subjects in the AIR and sleep education group getting better over time. And again, I think this is because everybody enrolled in the study has Gulf War illness, insomnia, and obstructive sleep apnea, and everybody's getting PAP. Here's the effects on pain, which I'm again measuring with the brief pain inventory. As with the last study, there's no group difference on pain severity. So veterans randomized to AIR and waitlist are both experiencing more or less the same amount of pain severity. There's no significant difference. But interestingly, pain interference, there is a main effect of time. So both groups, even though they're feeling pain, that pain is interfering less with their day-to-day activities as they progress farther along in the study. So, the longer they use their PAP devices, I think. And so here are the effects on fatigue, which I'm measuring in this study with the multidimensional fatigue inventory, or the MFI. So the MFI has many different measures of fatigue. And right now, I'm only seeing a significant group by time interaction on this measure of general fatigue, with the veterans in the AIR group showing a decrease in general fatigue over time, much more so than the veterans in the sleep education group. For most of these other measures of fatigue, veterans in both groups are feeling less physical fatigue over time, less mental fatigue, and this measure of total MFI, which is a combination of all of these measures. And so here are the effects at the 3-month follow-up. As with the CBTI trial, veterans randomized to AIR are able to maintain the gains that they achieve after therapy ends. So I mentioned earlier that the one main difference between this AIR treatment and just regular CBTI is this added component of PAP desensitization and PAP adherence. So you may ask, are people randomized to the AIR group more compliant with their PAP usage than people in sleep education? And the answer to that question is an absolute yes. So here again, AIR subjects' data are shown in blue. Sleep education subjects' data are shown in orange. This here on the y-axis, I'm showing percent PAP usage. This is 100%. And you can see by week 3, subjects randomized to AIR are nearly 100% compliant, whereas subjects in the sleep education group at week 3 are just barely above 60%, and they use it less and less as the study goes on. Now, we do see a drop in compliance at the 3-month follow-up, but these veterans are still using their PAP devices at greater than 75%, which is the benchmark that Medicare uses to define compliance. So 3 months after AIR therapy, the patients randomized to that group are still compliant with their PAP devices. So in conclusion, I think the results from these 2 trials with Gulf War veterans suggests that helping veterans with Gulf War illness and insomnia to sleep better with CBTI not only improves insomnia, but it also helps the veterans with their non-sleep Gulf War illness symptoms. The veterans are able to maintain the gains that they achieve after completing CBTI, so the habits and behaviors that they learn that they need to do to promote good sleep, they are able to keep doing once the treatment is over. And for veterans who have gulf war illness, insomnia, and obstructive sleep apnea, combining elements of PAP desensitization and PAP adherence techniques with CBTI may be a good option for treating these veterans' sleep and gulf war illness symptoms. Thank you. And here's my email if you have any questions or would like to know anything more about the study. This is our ongoing Gulf War Air study. So treating veterans with Gulf War illness, insomnia, and obstructive sleep apnea. And here's the link for the first Gulf War CBTI study. So thank you.